Let us study anal canal under the following headings: Introduction, External Features, Relations, Internal Features, Sphincters of anal canal, Development, Blood Supply, Lymphatic Drainage, Nerve Supply, and Applied Importance.
Anal canal. Anal canal is the terminal part of the large intestine and it is the continuation of the rectum. What you are seeing, this much portion is the rectum. Now the backward continuation, this backward turn from the rectum is called the anal canal. So this much is the anal canal. Anal canal is compressed side to side. Okay, anal canal is compressed side to side. And when we see the distal opening, it is in the form of an anteroposterior slit. You see the distal opening of the anal canal, it is in the form of an anteroposterior slit because of the compression by the anal sphincter muscles. Okay, muscles which form the anal sphincters. That we will see later. The anatomical position of anal canal is like this. Okay, this is a rectum. Then the terminal part of the rectum turns backwards. Okay, turns backwards to form the anal canal below the level of pelvic diaphragm. So this is the position where the pelvic diaphragm is located. Okay, below the level of pelvic diaphragm, the anal canal extends downwards. Okay, anal canal extends downwards from the level of pelvic diaphragm. So above the level of pelvic diaphragm, what we have is actually the rectum. This is a model of pelvis and the pelvic diaphragm. These are the muscles of the pelvic diaphragm. Okay, now we need to know about this muscle alone now. This is actually the puborectalis. This is actually the puborectalis. And the opening what we have here is through which the rectum is going to continue as the anal canal below the level of pelvic diaphragm. Okay, this is the opening where the rectum is going to continue as the anal canal. So this muscle is the puborectalis because it is looping over or it is forming a sling around the anorectal junction. Okay, form a sling around the anorectal junction. Because of this muscle and because of this sling, what happens is the anorectal junction will get compressed because of the sling and also the merging of internal and the external anal sphincter along with this muscle. Okay, along with this muscle, it will cause a compression here between the rectum and the anal canal, which will form a ring, which will form an incomplete ring. Okay, incomplete ring, which is more prominent on the posterior aspect when compared to the anterior aspect because the sling is deficient here in the anterior aspect. Okay, so this ring is called the anorectal ring. This can be felt perrectally. During a perrectal examination, this sling can be easily felt. And the ring which is felt here is actually the anorectal ring. Now we'll keep the model of rectum and the anal canal to understand the position. Okay, so the rectum is lying like this and the anal canal is continuing downwards like this after emerging out of this opening. Okay, in the pelvic diaphragm, and it is continuing backwards. Okay, and it is continuing backwards like this, and the opening is present here. This is actually the anal canal opening. Okay, this is actually the opening of anal canal. This is the position of the anal canal. You can see it is directed backwards. It is directed backwards and it is in the form of an anteroposterior slit. The canal is compressed because of the sphincters to form an anteroposterior split. Okay, slit, anteroposterior slit. And on either side of the anal canal, we have the ischioanal fossa. We have the ischioanal fossa, which is actually lodged with fat. Okay, for the expansion of the anal canal for the passage of feces. Okay, so there is ischioanal fossa on either side of the anal canal. Okay. Now the dimension of the anal canal. If you see the anal canal, the total length of the anal canal will be approximately 4 cm long. Approximately 4 cm long, which can be divided into 3 parts for our easy understanding to study the interior of the anal canal. Okay, so the upper part is approximately 15 centimeter, approximately 15 millimeter long. Then the middle part is again 15 millimeter long, and the lower part will be approximately 10 millimeter long. Okay, so this we will be seeing along with the interior of anal canal. Due to the external features of the anal canal, the classical features of the large intestine are absent in case of anal canal. Like example, the sacculations, the hausturations, aspirations of the circulations, the tinea coli, and the appendices epiploicae. So these three cardinal features of large intestine are absent in case of both rectum and the anal canal. Now let's study the relation of anal canal. Now we know the anal canal is passing through this opening. Okay, the anal canal is passing through this opening. So anteriorly, this is the anterior aspect, this is the posterior aspect. Anteriorly, it is related to this green structure. This is actually the perineal body, where all the muscles will be coming and converging through the perineal body. Okay, so anteriorly it is related to the perineal body, and in case of males, it will be related to the bulb of the penis here. Okay, so the penis will be coming here. So the bulb of the penis is related anteriorly, and also the membranous urethra which will be passing here. Okay, and also the membranous urethra which will be passing here. So the anteriorly it is related to the perineal body, the membranous urethra, and the bulb of the penis in case of males. Coming to the posterior relation, so for that we will see the inferior aspect. If you see posteriorly, so here will be the anal canal. Okay, so the anal canal is coming through this opening. So posterior, this is the posterior aspect. This is the posterior aspect. So posteriorly, it is related to, we can see these are the coccygeal bones. Okay, this is the coccyx. So it is related to the coccyx, and this ligament which is extending here, this is actually the anococcygeal ligament. It is related to anococcygeal ligament, coccyx. Okay, and on either side, already we discussed, it is related to the ischioanal fossa. On either side, it is related to the ischioanal fossa. This is about the relation of anal canal. Next, let's study about the interior of anal canal. To study the interior of anal canal, we'll section the anal canal like this. Okay, we'll take a section like this and we'll open up the anal canal. Once we open up the anal canal, we can study it under three different parts: the upper part, the middle part, and the lower part. So the upper part is 15 millimeter long, the middle part is 15 millimeter long, and the lower part is approximately 10 millimeter long. Okay, now we'll see, this is the upper part which is being represented by this pink color. Then we have this the middle part and this is the lower part. Okay, so let's see each part separately. First, let's see the upper 15 millimeter part. Okay, so this part is having many longitudinal mucosal folds. Interior is having many longitudinal mucosal folds. These elevated mucosal folds are called the anal columns. You can see these are called the anal columns. Okay, these anal columns will be united inferiorly by short transverse mucosal folds. You can see these are the short transverse mucosal folds which are bridging the anal columns. And these columns, these bridging mucosal folds which are transversely placed are called the anal valves. Okay, are called the anal valves. This anal valve is completely surrounding the circularly around the anal canal at this position, and this anal valve, the continuous arrangement of anal valve will form a line called the pectinate line. Above the anal valve, there is a depression here. You can see there is a depressed part here, and these depressed part, these depressed parts here is called the anal sinus. These depressed part are called the anal sinus. The importance of this anal sinus is the anal glands will be opening via this anal sinus. Okay, the anal glands which will be secreting the mucus which will lubricate the fecal matter will be actually opening via this anal sinus. These anal glands will be usually present along the innermost layer, that is the mucosa and the submucosa, usually in the submucosal layer. Sometimes it can even extend or penetrate into the muscle layer. Okay, it can penetrate into the muscle layer, which will be opening via a small crypt into the anal sinus. Okay, it will be opening via the small crypt into the anal sinus. So the mucus will be coming out through this region. And sometimes these anal valves will be projecting little more, okay, into the lumen. These anal valves may be projecting little more into the lumen of the anal canal, and these projections from the anal valve is called the anal papillae. This anal papillae will be representing embryologically a remnant of a membrane which will be separating this upper part of the anal canal from the lower part of the anal canal. Okay, embryologically there will be a septum which will be separating these two. In later on in life, during the development, the septum will disappear or it will break open to form a continuous canal. So that septum is actually represented by these small tags which are present here, which are called the anal papillae along the anal valve. Now coming to the middle part. So the middle part is approximately 15 millimeter long, okay, approximately 1.5 centimeter or 15 millimeter long, and it is bluish in color. The mucosa, it looks bluish color because below the mucosa we have a large plexus of venous, numerous venous plexus which are located just underneath the mucous membrane, and hence it is looking bluish in color. The middle part will look bluish in color, and the mucosa is also closely adherent at this part. It is not very loose. Okay, it is closely adherent to the next layers, and hence it is not lax. And this middle zone is called as the pecten. Okay, this line is the pectinate line, and this middle zone, this entire zone is called the pecten. Okay, this entire zone is called the pecten. Otherwise, we can call it as a transitional zone. Why we are calling it as a transitional zone is because this upper part is developed from the endoderm, and hence it will be having a simple columnar or sometimes stratified columnar epithelium, and this part will be a transitional zone where the simple epithelium will start converting into a stratified epithelium, and below this level it will be continuous with that of the skin. So it will have epithelium just like the skin. So this area we have a transition between simple and the compound epithelium, and hence it is called transitional zone, otherwise called the pecten. And this area is more for carcinomatous changes. Okay. So this transition zone is usually having a stratified epithelium, which is a stratified squamous epithelium, but will not have keratin. It will not have keratin, it will not have sweat glands, and it will not have sebaceous glands. Okay, that is about this transitional zone. Coming to the lowermost part, this is called the cutaneous part. Okay, this is called the cutaneous part because it is also lined by the epithelium of the skin, that is the stratified squamous keratinized epithelium, which will also have the sweat and the sebaceous glands, The junction between this middle part and the lower part, this line is whitish in color. Here it looks whitish in color, and hence this line of demarcation between the middle part and the lower cutaneous part is called the white line of Hilton. This line is called the white line of Hilton. The internal anal sphincter is absent below this white line of Hilton. Okay, the internal anal sphincter is extending only up to the level of white line of Hilton. Below that we don't have the internal anal sphincter, only the external anal sphincter is present. Next, let's study about the anal sphincters. Anal sphincters are two sets. There are two sets of anal sphincters in the anal canal. Okay, one is the internal anal sphincter and other one is the external anal sphincter. This internal anal sphincter is nothing but the modification or thickening which is present in the circular muscle coat of the anal canal itself. Okay, the circular muscle coat of the anal canal gets thickened to form the internal anal sphincter, and it is voluntary. It is actually involuntary in function. Okay, it is under involuntary control. It is under the involuntary control. Okay, this is actually the internal anal sphincter, and it occupies around 3/4 of the length of the upper 3/4. Okay, upper 3/4 of the length of the entire anal canal. See, the lower 1/3, that is lower 10 millimeter, will not have this sphincter. Okay, so it is ending at the white line of Hilton. Here we know it is having this line is called the white line of Hilton. So it is extending only up to the white line of Hilton. Below that it is deficient. So next set of sphincters are the external anal sphincters. These external anal sphincters are striated muscles. It is made up of striated muscle, and it will extend to the whole length of the anal canal. Now we'll see. Okay, the external anal sphincter is striated muscle, made up of striated muscle, and it is extending to the entire length of the anal canal. This external anal sphincter, see, now this orange color represents the striated muscle, which is the external anal sphincter. It is made up of three parts. We can see this part which is near the outermost region, that is the terminal 10 millimeter of the anal canal, and this is related to the skin. Okay, so it is called subcutaneous part. Okay, it is called the subcutaneous part, and this is the superficial part, and this is the deep part. Okay, so there are three parts for the external anal sphincter, that is the subcutaneous part, the superficial part, and the deep part. As we see, the subcutaneous part is present in relation to the terminal 10 millimeter of the anal canal, that is below the white line of Hilton. Okay, so below the white line of Hilton, the internal anal sphincter is absent, only the external anal sphincter is present, that is the subcutaneous part. Next is the superficial part. Superficial part is present in relation to the middle region, that is the middle 15 millimeter of the anal canal, that is the pecten. Okay, that is related to the pecten region. Then the upper part, okay, that upper part, the beginning 15 millimeter of the anal canal is surrounded by this set, that is the deep set of the external anal sphincter. This is a deep part of the external anal sphincter, and we can see this deep part and this internal anal sphincter here at the beginning will be merging with that of the levator ana muscle, that is the puborectalis. Okay, so this one, so it will be merging with the puborectalis. Okay, the superficial and the deep sphincters at the beginning of the anal canal will be merging with that of the levator ana muscle. Okay, that is the puborectalis. This external anal sphincter is under voluntary control. Okay, and it is innervated by the inferior rectal nerves. It is innervated by the inferior rectal nerve and the perineal branch of fourth sacral nerve. Okay, it is innervated by the inferior rectal nerves and the perineal branch of fourth sacral nerve. Next, coming to development. If you see the development of anal canal, it is derived from two different sources. One is from the hindgut. Okay, we know the gut tube has got foregut, midgut, and hindgut. So the terminal part, the hindgut. Okay, so just consider this as the hindgut. So the terminal part of the hindgut will be forming the anal canal, and along with the hindgut, from the surface epithelium, there will be a pit which is formed, which is called proctodium. Okay, this is actually the proctodium. Okay, that is called the proctodium. Initially, there is a membrane which will be separating this hindgut from the proctodium. Okay, this membrane is the anal membrane. Okay, anal membrane, which will be separating the terminal part of the hindgut from the proctodium. So this terminal part of the hindgut and this proctodium together will form the anal canal. Okay, will form anal canal. So during the development, this anal membrane will rupture. Okay, that will be represented here along the anal valves. So whatever the tags you are seeing here, it is actually the ruptured anal membrane. Okay, so above this will be developed from the hindgut. So this much part is going to develop from hindgut, and here the lower part below the pectinate line is going to develop from the proctodium. Okay, it is going to develop from proctodium, and hence this area, okay, above the pectinate line will be lined by the lining epithelium, the hindgut itself. Okay, mostly the simple epithelium, simple columnar epithelium, or sometimes during the lower, when it comes to the lower end, it may become stratified columnar epithelium. Okay, and here this lower part, since it is from the proctodium, from the surface invagination, it will be lined by compound epithelium. Okay, mainly the epithelium of the skin. Okay, epithelium of the skin, that is the stratified squamous keratinized epithelium at the lower part, and the stratified squamous non-keratinized epithelium at the middle part. Here, the middle part is lined by stratified squamous non-keratinized epithelium, and this lower part is lined by stratified squamous keratinized epithelium. And similarly, the blood supply also. Okay, so now we can study the blood supply along with this developmental source itself. The hindgut is going to be supplied by the inferior mesenteric artery. So the branch which is coming from the inferior mesenteric artery will also supply this upper part of the upper part of anal canal. So this is the aorta, and so this is the aorta, and this is the inferior mesenteric artery. The terminal end of the inferior mesenteric artery is actually the superior rectal artery. Okay, this is actually the superior rectal artery. Superior rectal artery, which is a branch of inferior mesenteric artery, which is the artery of hindgut artery. Okay, it's the artery of hindgut, which is going to supply the upper part of the anal canal. Now the lower part of the anal canal, since it is developed from the proctodeum, that is from the surface invagination, it will be supplied by inferior rectal artery, which is actually a branch of the internal iliac artery. The internal iliac artery will divide into an posterior branch, posterior division, and an anterior division. So this anterior division of the internal, this is the internal iliac artery. So posterior branch, and this is the anterior branch. This anterior division will give the inferior rectal artery. Inferior rectal artery. So this inferior rectal artery, which is a branch of the anterior division of the internal iliac artery, will supply the lower part of the anal canal. The middle rectal artery, which is again a branch of the anterior division of the internal iliac artery, will form anastomotic channels, and which will aid in supplying the anal canal, which will also form the anastomosis with the superior and the inferior rectal arteries. This is the middle rectal artery. Okay, which will form anastomosis between the superior and the inferior rectal artery and aid in the supply of the anal canal. Okay, this is the middle rectal artery. This is about the blood supply of anal canal. Next, coming to the venous drainage. So the venous drainage of anal canal is very important to understand the piles, that is the hemorrhoids, understand the mechanism of hemorrhoids. Okay, so since it is developmentally from both hindgut and from the proctodeum, the venous drainage is also having two different sources. Okay, one is draining into the portal vein. Okay, the other source is draining into the inferior vena cava. So it is having two systems of veins. So it is drained by two systems of veins, that is the portal venous system and by the inferior vena cava. So usually the submucosal coat of the anal canal will have lot of venous plexus, and these venous plexus are called internal rectal venous plexus. Okay, so submucosa will contain internal rectal venous plexus, and these internal rectal venous plexus will drain in two directions. One is towards the portal vein. Okay, the other one is towards the inferior vena cava. So all are starting from the internal rectal venous plexus. Okay, so the areas which are present above this level, that is, this is a pectinate line. Okay, so above the pectinate line is draining into the portal vein, and area which is below the pectinate line will be draining into the inferior vena cava. So how this reaches the portal vein? So initially the venous plexus will drain into the superior rectal vein. Okay, it is carried via the superior rectal vein. From the superior rectal vein to the inferior mesenteric vein. Okay, it will follow the artery. Okay, so into the inferior mesenteric vein, and this inferior mesenteric vein will be draining into the splenic vein. Okay, it will be draining into the, so this is actually the splenic vein, draining into the splenic vein, draining into the splenic vein. So this splenic vein along with the superior mesenteric vein, it will form portal vein. So thus it reaches the portal vein. Okay, so the plexus are draining into the superior rectal vein, which is draining into the inferior mesenteric vein, which drains into the splenic vein to reach the portal vein. Okay, so this is the venous drainage of the upper part above the pectinate line. So below the pectinate line, it is drained by the inferior rectal vein. Inferior rectal vein. Okay, drained by the inferior to reach the internal iliac vein, from there to the inferior vena cava. Okay, from there to inferior vena cava. That is the venous drainage. Okay, that is the venous drainage of the lower part. And there are some middle rectal veins also, which will be found anastomosing between the superior and the inferior rectal veins. So the middle rectal veins will be anastomosing between the superior and the middle rectal vein, which will be draining mainly the ampulla, that is mainly the muscularis externa region of the ampullary portion of the rectum. So apart from these venous anastomosis, this internal rectal venous plexus, okay, the internal rectal venous plexus will also receive arterial anastomosis, So it contains multiple arteriovenous anastomosis, which forms the which will be from the superior and the middle rectal arteries also. Okay, which will be mainly from superior and the middle rectal arteries also. It will receive some arterial anastomosis. Since we have studied this much, we can understand now the mechanism and the position of hemorrhoids. Okay, we can understand the mechanism and position of the hemorrhoids. Already I said the submucosa is very vascular, is highly vascular, and this vascular submucosa is thickened in 3 positions. It is mainly thickened in 3 positions. We can study by drawing a section, or we can study by seeing a anal canal in a rounded section. Okay, a rounded section, like you can imagine it as a clock. Okay, when we view the perineum from below, we can understand the anal canal with a section. We can study the anal canal of the section to understand the position of hemorrhoids, and you can try to recollect by understanding it with the clock positions. Okay, so the submucosa is thickened in 3 different positions. So which are the position which is thickened? The left lateral position, okay, is a left lateral position. We can call it as 3 o'clock position. Okay, just imagine a clock. So this is actually the 3 o'clock position, that is the left. So this is the left side, the right side. Okay, so this is the left lateral position, that is the 3 o'clock position. This is the first side. Then right anterolateral position. So is the anterior, little lateral towards the right. So this is a right anterolateral position, is a 11 o'clock position, which is the 11 o'clock position. Okay, this is the right anterolateral, is a left lateral. Then the last position is the right posterolateral position. Okay, right posterolateral position, which is 7 o'clock position. This is 7 o'clock position. Okay, that is the 7 o'clock position, which is the right posterolateral. And right posterolateral. So these are the 3 common sites of the hemorrhoids. Okay, these are the 3 common sites of the hemorrhoids. Okay, so when we do a digital examination, we can find out the mucosal thickening, the submucosal thickening, which will have these internal hemorrhoids, if there are hemorrhoids. Next, coming to the lymphatic drainage. This lymphatic drainage also follows 2 different paths depending on the developmental source itself, that is the pectinate line. This is the pectinate line. So above the pectinate line, So this is the pectinate line. Above the pectinate line, the lymphatics will be draining into the internal iliac nodes. Will be draining into internal iliac nodes. Okay, it will be draining into the internal iliac nodes. From the internal iliac nodes, it will go to the common iliac nodes, and from there to the lumbar nodes. Okay, from there to the from the internal iliac to the common iliac nodes, from there to the lumbar nodes. Okay, this is about the lymphatic drainage above the pectinate line. Okay. Now, the lymphatic drainage below this pectinate line is into the superficial inguinal nodes. Okay, into the superficial inguinal nodes. So this is about the lymphatic drainage of the anal canal. Next, coming to the nerve supply. Nerve supply of the anal canal. Okay. Depending on the two different sources of development, that is below and above the pectinate line, the nerve supply also differs. So above the pectinate line, it is mainly receiving the visceral innervation. And below the pectinate line, it is mainly receiving the somatic innervation. Okay, somatic innervation. So this visceral innervation is coming via inferior hypogastric plexus. Inferior hypogastric plexus. So it will be containing sympathetic, parasympathetic, and the visceral efferent fibers. Visceral afferent fibers. Okay, and the visceral afferent fibers. So it is containing sympathetic, parasympathetic, and visceral afferent fibers. This yellow structure is the internal anal sphincter. So the sympathetics will be supplying this internal anal sphincter and maintain the tone of internal anal sphincter. Okay, it maintains the tone of the internal anal sphincter. The parasympathetic fibers will supply this internal anal sphincter and it will be inhibiting the tone. Okay, or it relaxes the internal anal sphincter. Okay, parasympathetics relaxes the internal anal sphincter and thus helps in the relaxation and evacuation. Okay, evacuation of the feces. Okay. Superior to the pectinate line, okay, superior to the pectinate line, this region of the anal canal is only responsive to the stretch. Okay, it is not having the pain perception. For example, the distension of the rectal ampulla, okay, will cause stretching reflex. Okay, and it will cause relaxation. Okay, that is the parasympathetic nerves are activated and it causes relaxation of the internal anal sphincter. Okay, so that is about the area above the pectinate line, nerve supply of the area above the pectinate line, that is the visceral. Then now we will study about the area supplied below the pectinate line. Okay, the nerves which are supplying below the pectinate line, which are supplied by the somatic nerves, which is supplied by the inferior rectal nerve. Inferior rectal nerve, which is actually a branch of pudendal nerve. Okay, it's a branch of pudendal nerve. Since it is supplied by the somatic nerves, okay, since it is supplied by the somatic nerves, the region below the pectinate line is sensitive to pain, touch, and temperature. Sensitive to pain, touch, and temperature. This orange color structure is actually the external anal sphincter, and this external anal sphincter is also supplied by the branch of the inferior rectal nerve, also supplied by the inferior rectal nerve, which carries S4, okay, which is supplied by the S4 through the inferior rectal nerve, and hence it is voluntary, okay, and hence the external sphincter is voluntary in function. This is about the nerve supply of anal canal. Now coming to the applied importance. First we'll study about the first applied importance, which is related to the mucocutaneous or the mucocutaneous line, which is the pectinate line. Okay, the mucocutaneous line or the pectinate line. This pectinate line is a very important line where there is a transition which is going to happen between the epithelium. So this zone is very important for surgeons to understand the various changes, the various carcinomatous changes which can occur at this region. Okay, so this region is prone for carcinoma. The pectinate line, the mucocutaneous line. Okay, so second one is the anal fissure. Anal fissures are the fissures which will be appearing along the opening, anal canal opening. These fissures will be painful because it is innervated by the somatic nerves. The terminal part of the anal canal is innervated by somatic nerves, and hence fissures in ANO is actually very painful. Okay. The next thing is the perianal abscess. Perianal abscess. The infections which are present along the anal canal or even the perianal the anal fissures, the infections which are developed in the anal fissures can spread laterally into the perianal space, and there can be accumulation of pus which can be seen in the perianal space. That is the ischioanal fossa. That's the ischioanal fossa. So the accumulation of pus here will form ischioanal abscess, which is also very painful. Okay. The next applied importance is the hemorrhoids. Okay. So these hemorrhoids, already we had discussed about the hemorrhoids when we studied about the venous drainage of the anal canal. So we know the positions of the internal hemorrhoids. Okay, we know the positions of the internal hemorrhoids. These are nothing but the prolapse of the mucosa and the submucosal venous plexus, which are present along the upper part of the anal canal. Okay, you can see it projecting downwards, which is containing the normally dilated veins. Okay, which is containing the normally dilated veins, and also it will also have the anastomosis from the arteries, the superior rectal, the middle rectal, and the inferior rectal arteries also, and hence these hemorrhoidal masses, when it projects down, sometimes it can extend down up to the anal canal opening. Okay, up to the opening of the anal canal. So when it projects down, sometimes it can get contracted or it can get constricted by the anal sphincters. It can get contracted and constricted by means of these anal sphincters. When it is constantly getting constricted by the anal sphincters, it can go in for strangulation or it can go in for ulceration. Okay, strangulation is nothing but the compression where the blood supply will be cut off, and ulceration is nothing but the wounds or the injuries which are happening along the hemorrhoidal mass. So the bleeding which are occurring from these internal hemorrhoids, which will be having the anastomosis of both arteries and the veins, is usually bright red in color because of the arterial component which are there inside this hemorrhoidal mass. The bleeding which are coming from this hemorrhoidal mass will be bright red in color. Since these projections or these hemorrhoidal masses are coming from above this line, okay, above the pectinate line, and it is supplied by the visceral plexus, okay, it is supplied by the visceral nerves. The mass which are arising from here are insensitive to pain. The mass which are arising from here are insensitive to pain. Only the external hemorrhoidal masses are sensitive to pain. The external hemorrhoids are the thrombosis of the veins which are covered by the skin, and it is appearing along the terminal part of the anal canal. It is appearing along the terminal part of the anal canal and it will be sensitive to the pain. Okay. Since the internal hemorrhoids are insensitive to pain, any resection or removal of these bile masses can be done without giving anesthesia. The causes of these internal hemorrhoids may vary. Okay, it is mainly associated with increased intra-abdominal pressure, constant increase in intra-abdominal pressure, like in case of constant coughing, constant sneezing, or difficulty in micturition, difficulty in defecation. So whenever there is an increased intra-abdominal pressure, it can cause hemorrhoids. It can cause hemorrhoids. And then since we also know this site is an important site for the portocaval anastomosis, whenever there is an increased portal venous pressure, in case of a liver disease or in case of a portal venous hypertension, all these conditions can increase the pressure inside the portal vein and it can also cause hemorrhoids. Okay, at last we can see about the last applied importance, that is the anorectal incontinence. This anorectal incontinence is caused due to the stretching of the pudendal nerve and the traumatic injury of the pudendal nerve during difficult childbirth. Okay, during the difficult childbirth, if there is an injury to the pudendal nerve, it can cause anorectal incontinence. So these are all the applied importance of the anal canal. Thank you.